You can have the patient having more than one of these types of cerebral palsy. We call that the mixed cerebral palsy. And the most common combination is spasticity or the spastic cerebral palsy, and then the atetoid or the dyskinetic cerebral palsy. And this is because they have multiple injuries to various parts of the brain. So this is a diagram that is just summarizing all that I've said in the past 20 or so minutes. The spastic cerebral palsy, the injury is to the cortex. The dyskinetic cerebral palsy, the injury is to the basal ganglia. The ataxic cerebral palsy, that has the injury to the cerebellum. And the mixed cerebral palsy may have multiple areas affected. The spastic cerebral palsy may be hemiplegic. If only one side is affected, it may be diplegic if the lower limbs are more severely affected than the upper limbs. So see that in the picture here, the lower limbs, both lower limbs and upper limbs are affected, but the lower limbs are darker. I mean, the dark blue is the lower limbs. So as compared to a light blue, which is the upper limbs, which is saying that the lower limbs are more severely affected than the upper limbs. Then the quadriplegia, which has the whole body affected, and then the atetoid also tend to have the whole body affected. So cerebral palsy often comes as a package. Unfortunately, you have a whole box of comorbidities with these patients, and the most common ones are the developmental delays and the seizures. They may also have visual abnormalities, including cortical visual impairment, refractory errors. They may have squints. They may have hearing impairment. Speech defects is common. Learning disabilities or intellectual disabilities is also a common comorbidity. For us pediatricians, feeding problems or swallowing difficulties is a very big comorbidity for us. We often want to make sure our patients are well nourished, but if they have challenges with swallowing, then they tend to have feeding problems. And that's for that same reason, they also tend to have recurrent aspirations. So they often come on admission with pneumonias because they aspirate their secretions or sometimes even the food that is offered them. Then they may have gastroesophageal reflux. It is very common because the children do not complain. We often don't think about it, but always think about patients with cerebral palsy, especially the spastic quadriplegians, as having gastroesophageal reflux. They may have gait abnormalities. That's for those who get ambulatory. Contractures are common. Hip subluxation in the spastic diplegias. And then because of all these problems put together, they may have failure to thrive. Some of them may suffer neglect or abuse. And then when they grow older, behavior and emotional problems set in, such as ADHD, depression, ASD, as we just heard some minutes ago. So we need to make a diagnosis of cerebral palsy. And the diagnosis is clinical. There is no test that we do that gives us the diagnosis. It is clinical based on a good history and a thorough examination, and sometimes periodic reviews. You need to see the patient again. You may not be able to get a diagnosis at the very first encounter with the patient. Remember, we said that the manifestations may evolve over time. Then when you have made your diagnosis, some of the times you want to do imaging just to support your diagnosis. For older children who still have their anterior fontanelles patent, you may do for younger children, you may do an ultrasound, but for older children, CT scan or MRI will often be helpful in helping you identify what the pathology is. There are some features that when you see, you should think about some other conditions different from cerebral palsy. Most of the time, we box all neuro-disabilities into cerebral palsy. So we get all sorts of patients referred to us as having cerebral palsy, but you realize that they have something else. So we need to look beyond that. Cerebral palsy, as I said, three key things. They should have had motor or movement impairments. There should be some clue to an insult in the perinatal period, prenatal, perinatal, or postnatal period up to 2 years. And then, so those are the things you should look for. But sometimes you may not see these things. Look beyond cerebral palsy. If you have a patient whose head circumference keeps increasing, it may not be cerebral palsy, or it's most likely not cerebral palsy. Think of a tumor, think of hydrocephalus, think of white matter disease like the leukodystrophies. Eye abnormalities such as squints are fine because we tend to see them a lot in cerebral palsy. But if you have a patient with cataract, think of a metabolic disorder, think of a neurodegenerative disorder. If you send a patient to ophthalmology and they say he's got retinal pigmentation, look for neurodegenerative disorders. If you have skin manifestations such as hypopigmentations, cafe au lait spots, think of neurocutaneous manifestations. If you have organomegalies like hepatomegaly, splenomegaly, think of storage diseases. All these will present with neuro-disabilities. So, but it doesn't mean they are all cerebral palsies. We didn't mention sensory manifestations in our patients with cerebral palsy because their senses are fine. I mean, I'm not talking about special senses. I'm talking of touch, or deep touch, light touch. So if you have patients with abnormalities with deep touch, light touch, often think beyond cerebral palsy and look for other conditions like peripheral nerve disease or other things like that. So this is a table that I often like to show. If you have polyneuropathy, think of these conditions, including the leukodystrophies or the white matter disease. If you have ataxia, ataxia may be cerebral palsy. Remember the ataxic type of cerebral palsy, but that's very rare. So if you have ataxia, most of the time you want to think of ataxia telangiectasias, Friedreich's ataxia, spinocerebellar ataxia, and other genetic conditions. If you have spasticity with chorea, it may be the mixed type of cerebral palsy, but also think of other conditions like Niemann-Pick's disease or Rett syndrome. And then if you have a child presenting with floppiness, yes, the hypotonic type of cerebral palsy initially may come as floppy, but think of other conditions, Down syndrome. And sometimes it's unfortunate that we get a lot of patients with obvious Down syndrome referred to as having cerebral palsy. Think Down syndrome in floppiness. Think storage disease like Krabbe's, or think of anterior horn cell disease like spinal muscular atrophy. Even hypothyroidism, very, very important to make that diagnosis, because making that diagnosis is life. There is life.
Hello?
Very happy. How is it now? The place is fine. Let me have a look. Yeah. There's some funeral, some quite. Just a group. With a cyst, water inside. Yeah, there's water in the group. So you're fine. Oh, thank God.
All right. Thank you for the patience that you are having with us. We are sorry we had a challenge with a tender. So we lost Prof. Hammond, but we're working to bring him on soon. Thank you. Dr. Marilyn. Please, are you online?
Yes, I'm here.
Okay. I think whilst waiting for Dr. Hammond, if we can start asking some of the answering some of the questions that were directly addressed to your presentation, that would be fine.
Okay, I'll do that.
Okay, thank you.
I saw one that asked about when it comes to diagnosis, what's the clinical distribution across patient symptoms? Do clinicians rely more on the sensory symptoms than other motor and cognitive symptoms? Okay, so the DSM-5 or the ICD-10 has specific criteria that you have to meet to make a diagnosis of autism. So the section A talks about social communication skills, and they'll give you examples of what they mean there. And then the section B talks about the repetitive or restricted interest or sensory. And there's a criteria. You need 2 in the section B, and you need to meet all the criteria in the section A. So they don't depend on one particular one. You just have to follow the criteria and make sure that you tick all the boxes. The second question says, considering that a lot of the neurologic population are pediatric, is the interview-based diagnostic tool based to bias to the responses? Feedback, I can't read this. Feedback from parents guiding. Yeah, so the interview, so these are children who, if it's in the pediatric population, yes. So the responses would be questions that the parents are answering, questions that the teachers are answering, and the questions that you, the diagnostician, is also observing to answer. So for example, if you ask that, do they point? You just don't take the word of the parents and say, yes, they point, because a lot of the time you say, oh, yes, he points. So then I ask, is he pointing this way? And by the time you finish the evaluation, if the child can point, the child should have pointed for you to see. Most of the time, if you would then demonstrate what you are talking to, be like, No, he doesn't point. He would rather use your hand to do this. So even though it's an interview and you are depending largely on the response of the parents, you are also doing the observation and looking at it. And if you think the parent is not giving you consistent answers, you would then want to go further and get information from teachers, grandparents, etc. I hope I've answered your question. When we are doing assessments for adults who are verbal and can talk, then you can ask the adults themselves the interview and they can answer themselves. When it comes to biomedical treatment, is there a consideration for neurological implants or assistive technology? So we have assistive technology for communication. So AACs, the speech therapist will talk about AACs, which is augmentative alternative communication. So if the individual is nonverbal, there are apps on tablets and things that they can use to communicate. We can do very basic ones like the picture exchange communication systems where you're using pictures and visuals to be able to communicate. I am not aware currently of any implants that would be used in autism.
Okay.
I think
Doc,
I
thank
have
you.
answered. Okay.
Yes.
Yeah.
Yes. Thank you, Doc. I think Doc Hammond is back.
Okay.
Doc, please, can you hear? I see you online.
Yes, please, I'm back. Unfortunately, I'm logged out on my laptop, so I'm back on my phone, and so I may not be able to share, but I'm almost done. I was just talking about the management in the next 2 or 3 slides, and I was going to be done. So maybe I can just continue, but unfortunately, I will not be able to share. So I was talking about the management of the child with cerebral palsy, and the key thing here is that it is a multidisciplinary team approach. No one specialty manages a child with cerebral palsy. However, the child should be under the care of one key practitioner. So that person can be, ideally, that person should be a developmental pediatrician, but we don't have developmental pediatricians in numbers in Ghana. So a pediatrician can do this, a pediatric neurologist can do this, a medical officer can do this. So these persons are usually the ones under whose care the child is, and they coordinate the care of the child between the other specialties. The other specialties will include audiologists for hearing assessment, speech therapists. They assess speech, they assess swallowing, and then they aid with swallowing. Ophthalmologists for the visual complications that I mentioned. We often want the dietitian or the nutritionist on board because of the feeding problems. The physiotherapists, obviously, they take a very center stage because of the spasticities, the movement problems, and also the orthopedic surgeons are important. Sometimes we rely on them to release the contractures for our patients to be comfortable. And then also occupational therapists, they're also very key as they help with fine movement activities and some of the activities of daily living. We also have special teachers. They should also get on board with the management because some of these children will require specialist teachers, clinical psychologists, social workers are so key that they should be involved with the care of the child who has cerebral palsy. Not only the child with cerebral palsy, but any child with neuro-disabilities will require the intervention of social workers. And I was going to show a diagram on the management of spasticity, but because I can't show it now, just talk briefly about it. Spasticity, the interventions are many for managing spasticity. It depends on whether you are looking at focal spasticity or generalized spasticity. So some things like surgery will be for focal. If you have a patient with generalized spasticity and you say you are doing surgery, you wouldn't know where to touch. But if it's specifically in the Achilles, for example, the Achilles tendon, then you can do tendon release in the Achilles tendon to release that spasticity. Botulinum toxin injection is also one of the newer innovations, and it's used for managing focal spasticity. Of course, you can't use it for generalized spasticity. For generalized spasticity, you want to do oral therapy with antispastic drugs like the one we often use. Sometimes we use, and I think some other person is also unmuted. Can we all stay muted? So we use medications like baclofen for oral therapy, and it's for generalized spasticity. In some places, they are doing surgeries, including selective dorsal rhizotomy, where they select some of the dorsal nerve roots and cut them just to release or to decrease the spasticity, especially for patients with generalized spasticity. Some patients, some places, they are also doing intrathecal baclofen. They put a pump at the back of the patient, and they put baclofen in that, and then that pump releases baclofen into the intrathecal space from time to time. Or sometimes they put a device in the basal ganglia, especially with those who have basal ganglia pathology, and that is called the deep brain stimulation. And this device sometimes will reduce all the discharges coming from the basal ganglia and then reduce the spasticity. There are also some current innovations which are still experimental. And one of them is therapeutic cooling or systemic hypothermia, especially for babies who suffer hypoxic ischemic encephalopathy. It has been found out that controlled cooling of the body, to reducing the core body temperature, protects the brain, and it reduces the rate at which death or disability results from brain injuries. So it has been shown to, studies have been done, it has been shown to be effective in patients with severe hypoxic ischemic encephalopathy. There are two types. It's either head cooling or total body cooling. But at the moment, we are not doing any of that here in Ghana. One other thing that most patients will come and ask you about, most parents will come and ask you about, is stem cell therapy. Some studies have shown that it may be protective because stem cells have the ability to transform into other cells, including transforming into neural cells to replace the damaged cells. So some studies have shown that it may be effective, but it is still experimental and it is not in clinical practice yet. So I think, yes, I will end on that note. I will say that when it comes to prognosis, it depends on the comorbidities and how well your comorbidities are managed. The lifespan, because cerebral palsy is a static insult, if there are minimal comorbidities, these patients can live into adulthood. In the US, as of 2008, the average lifespan for patients with cerebral palsy was 35 years. I'm sure that 15 years on, probably it has increased to maybe 40 or something. But I just want to say that if they are given the best of care, they can live into adulthood. So on that note, I will end here, and hopefully the reins will not take me out again so I can take all the questions. Thank you.
Thank you, Dr. Hammond, for this all-important topic. I love when you came to your management, the multidisciplinary approach. And on this platform, we have people from different areas. So we thank you so much for the hard work and the contribution that you've made into our medical knowledge this afternoon. Thank you. I'll hand over to Prof. Dobe. Thank you.
Thank you. Thank you. So that was another brilliant and exciting presentation. And well, time will permit, we'll take the last speaker. So now that we are migrating from childhood to adulthood, Dr. Steve Sappho will put us to strokes the next 30, 45 minutes. So Steve, you have the platform. Over.
Hello. Oh, I'm mute.
Hello, Prof.
Yes,
go
please,
ahead.
can you hear me?
Yes, please, clearly. We can hear clearly.
Fantastic. Is my screen showing okay?
Yes.
The slides are showing okay. All right, thank
Yes.
you very much. So, so I'm happy to share with you updates on the management of stroke. These are just an overview of what we'll be touching on. Hello. Hello, can you hear me? It's raining.
Yes, Prof, we can hear you.
Yes, we can hear you.
Yes, please. Risk factors, pathophysiology, clinical features, diagnostic workup, acute management, secondary prevention, and I'll touch on subarachnoid hemorrhage. With most of the stroke lectures that I've given, I realized that I learn more, or we learn more when we have discussions, because stroke is such a big topic. So I'll try to go through as quickly as possible so that we can have time for input and discussions from folks. So when we say stroke, essentially it is a global or a focal neurologic deficit that results from either a bleed or an infarct of the central nervous system. And I want to remind you that the central nervous system is made up of the brain, the spinal cord, and then the retina and optic nerves. So if somebody has a vascular injury to the brain, spinal cord, or to the retina, the person is said to have had a stroke. And this is important to stress that in the past, we used to say when somebody has a neurologic deficit lasting for more than 24 hours, then the person has a stroke. But we've moved from this time-based definition of 24 hours to what we call a tissue-based definition. So if somebody has symptoms, neurologic deficits, and within, let's say, 2 hours, you're able to take an MRI, and on the MRI, you can demonstrate that there's evidence of infarction on the MRI, the person has had a stroke. If the person has a neurologic deficit, let's say the person has developed a sudden onset aphasia, inability to speak, or a sudden onset of weakness on one half of the body, and you do an MRI scan and you can find evidence of infarction, regardless of the duration of symptoms, the person has had a stroke. Now, if the same person presents with these deficits, aphasia or weakness, but you do an MRI, which is very sensitive, and you are not able to identify any area of infarction on the MRI, then the person is said to have had a transient ischemic attack. So that is a key difference between the two now. In the past, we'll say transient ischemic attack, the person has symptoms less than 24 hours, and a stroke when the person has symptoms for more than 24 hours. By that time-based definition, we've moved past that because we're realizing more and more that if you have an emergency such as a stroke, you don't have to wait for 24 hours to say that the person has had a stroke. And in fact, most of the interventions for the current management of stroke is time dependent, and you have to be able to administer your thrombolytic, whatever you want to administer to your patient as soon as possible, preferably less than 3 hours of symptom onset. So epidemiology of stroke, leading cause of mortality worldwide, adult disability, huge burden. Africa, as usual, everything we top it. So Africa incidence is very high. Mortality rate is 35%. 3-year mortality is 84%. So stroke mortality is quite high in our part of the world. So it's important that we upgrade ourselves in terms of our knowledge base of stroke so that we can improve the outcome, because stroke is everywhere. And we can't just wait for specialists and consultants in neurology to treat stroke. Everybody has to get hands on deck for us to be able to manage stroke. So this is one of the papers that we published, which shows that in Kumasi, the mortality rates for stroke after 72 months of incident stroke is about 59% for males and about 70.9% for females. So females tend to die more from stroke in the long term than males. It's age dependent. And also if somebody has had a recurrent stroke, the person has a higher probability to die in the long term than if somebody has the first ever stroke. So my question to you, and I want your answers in the chat box to show that you are paying attention. I want you to answer this in the chat box. Which one of the following is not a recognized non-modifiable risk factor for the occurrence of stroke? Which of the following is not a recognized non-modifiable risk factor for stroke? High birth weight, male gender, increasing age, African descent, genetic risk factors. Any answers, please? Any answers? Okay. All right, so it's high birth weight. So male gender increases with increasing age, increases risk. So when we say modifiable risk factors, usually anything that increases somebody's chance of developing a stroke is called a risk factor. So we have those that are modifiable, those that are not modifiable. Those that are not modifiable, you can't do much about it. But those that are modifiable are the ones that we tend to focus on. Because in reality, if somebody has a modifiable risk factor, such as hypertension, atrial fibrillation, dyslipidemia, diabetes, then those modifiable risk factors, if the person hasn't even developed a stroke and you identify those modifiable risk factors, you can do something about that risk factor that prevents the individual from developing a stroke in the first place. But even if the person has developed a stroke, then those modifiable risk factors are the things that you target or address to make sure that you are preventing the person from developing a recurrent stroke or vascular events. And there are things we call emerging risk factors, things like migraine, infection, inflammatory markers, sleep apnea, renal disease are all considered emerging risk factors. So the pathophysiology of stroke is heterogeneous, it has diverse mechanisms. So what tends to happen is that if somebody has, let's say, a blockade of an artery going to the brain, the blockade can be because there's a clot in the heart that has just gone through the arteries and blocked an artery. So that will be cardioembolic. You will see it as an infarct on a CT scan or an MRI, but the source is the heart. Or you can have a plaque in an artery that will rupture and then travel through the vessels and go and block an artery in the brain. So although you see an infarct, this infarct is coming from a ruptured atherosclerotic plaque. Or sometimes the very small vessels in the brain can be blocked and you can have an infarct. So the mechanisms for getting an infarct are diverse. And so when we see patients with a stroke, we try to understand what is the mechanism for that stroke, because that impacts on how you manage the patient in the long term. And to be able to identify the mechanism, take a history, examine the patient, and then you order the appropriate laboratory workup. So as I mentioned, when we have strokes, it can be a large artery atherosclerosis, a cardioembolism, it can be a small vessel occlusion, or sometimes you can have stroke from other determined causes. Those are not very common. In fact, in my practice, the common ones I see are the small vessel, or we call the lacunar strokes. Small
Hello, Prof. Please, we are having some hitches, as you can see. Sorry. I will get back to you soon. Thank you.
It's raining heavily here, so I apologize.
That's okay, bro. Go ahead,
Yes,
sir. Thank you.
So please, what I was saying is that lacunar strokes are the commonest type of ischemic stroke that you come across in practice. This is based on work published in 2022, work done between Ghana and Nigeria across 16 sites, over 2,431 ischemic stroke patients. So I think this, for those of us who have been doing CT scans, I'm sure you will realize that most of the stroke that we see is a very small occlusion, a very small dark spot that is responsible for the symptoms and the signs that we see. Large arterial sclerosis comes second, and then cardioembolic comes third. But for about a third of our patients, we are able to determine whether it is a small vessel occlusion or a large atherosclerosis or a cardioembolic stroke. So sometimes we say the cause is undetermined. So we have to apply the same principles to when a person comes with an intracerebral hemorrhage or a bleed. When somebody comes with an intracerebral hemorrhage, what is possibly causing the arteries in the brain to bleed? So the acronym for remembering is called SMASH-U. Let's all say it together, SMASH-U. Let's say it together, SMASH-U.
SMASH-U.
Good, so SMASH-U, S is for structural lesions, M is for medications, A for amyloid angiopathy, S for systemic disease, H for hypertension, and U for undetermined. Now I want to highlight hypertension because hypertension is the commonest reason why a lot of people bleed. And when somebody has hypertension and the person bleeds, it often occurs in the basal ganglia area, like the putamen, the thalamus, subcortical. So most of the bleeds that we see in practice are from hypertension. So the patient comes, the BP is around 230, 140 diastolic, high BPs, and it ruptures the vessel, and then we have a bleed. Occasionally, it may be due to structural malformations like an AV aneurysm or AV malformation or aneurysm. That's not very common. But it's always important to ask the patient is taking medications like warfarin or aspirin, because sometimes those could be the reason why the person could be bleeding. Again, work that we published in neurology in 2020 shows that hypertension is by far the commonest cause of intracerebral hemorrhage. So I know most of us don't like anatomy. I didn't like it myself, but I had to like it because of the neurology I chose to do. But basically, for us to remember, we know the brain is perfused by the internal carotid artery that breaks into the middle cerebral artery and the anterior cerebral artery. And then it sends the posterior communicating artery to join the vertebrobasilar artery to form the circle of Willis. Don't worry. I think what you need to remember is this, that if you look at the lateral aspect of the brain, the red part here shows the motor cortex representation, and the green part shows the sensory representation of the parts of the body in the brain called the homunculus. So if you look at the homunculus closely, the leg is very medial, and then the arm and face is very lateral. And this is important because the lateral aspect of the brain is perfused by the MCA, middle cerebral artery, and then the medial part of the brain, which perfuses the leg, is perfused by the anterior cerebral artery. And they have the posterior cerebral artery perfusing the occipital lobe, which is responsible for vision, and then also perfusing the cerebellum, which is responsible for balance. And so Dr. Hammond also, for instance, spoke about ataxia. So when somebody has a stroke that affects the cerebellum, the person will present with ataxia. But here, the reason why the person is having the ataxia is because the cerebellum is not being perfused. In cerebral palsy, for instance, it is a static lesion that occurred in the cerebellum that caused the ataxic cerebral palsy. In stroke, the ataxia is due to occlusion of a vessel supplying the cerebellum. Okay. So when somebody has a middle cerebral artery, neurologists, we are excited when we can see a patient and predict that, okay, because I've seen hemiplegia, weakness on one side, because I've seen hemisensory loss on one side, because I've seen contralateral gaze palsy, and all these signs are, for instance, on the right side, we can predict with about 99.9% certainty that because it's right-sided weakness, the lesion will be in the left side of the brain. And we'll go and do the CT scan, and lo and behold, it confirms it. Then we pat ourselves to the back that, yeah, we got it. So the neurologic deficit that the patients come to you with can also be predicted if you know how the brain is perfused. So if somebody has a middle cerebral artery occlusion, they'll have hemiplegia, hemisensory loss, gaze palsy, they'll have hemianopsia sometimes, which is they are not able to see one half of the world. One half of the world is blind. And that they can have global dysphasia, which is inability to communicate, especially when the lesion is on the left side, because the speech center is on the left side. When you have somebody with anterior cerebral artery infarction, remember that we said that the anterior cerebral artery perfuses the medial part of the brain. So that is where the leg homunculus is. So when you have an occlusion of the anterior cerebral artery, they tend to present more with weakness of the leg rather than weakness of the arm or the face. And they may have things like urinary incontinence, gait apraxia, and so forth. So when a patient comes to you and you think the person has a stroke, you have to have an approach of assessing the patient. Most of the things we do after stroke should not be lackadaisical. It's an emergency. So most of the things we do should be quickly done. For instance, you do a head CT scan as soon as you suspect you have a stroke, because that can help you determine whether it's a stroke or it's not a stroke. And if it's a stroke, is it ischemic or hemorrhagic? And if it is ischemic, what is the etiology of the stroke? What are the risk factors for this patient? And what are the complications that I anticipate will emanate from this stroke? So if you forget anything from this lecture, I want you to remember that when you take a CT scan and the person has an ischemic stroke, it appears as a dark or hypodense lesion. And then when you have a hemorrhagic stroke, it appears as a hyperdense lesion. If you don't remember anything from this lecture, at least I beg you, remember that if somebody has an ischemic stroke, it appears as a dark lesion. And then if you have a hemorrhagic stroke, it appears as a white or hyper-intense lesion, hyperdense lesion. So ischemic stroke is dark. Let's say ischemic stroke is dark on CT scan. Let's say together, ischemic stroke is dark on CT scan.
Ischemic stroke
on CT scan.
Hemorrhagic stroke is white.
Hemorrhagic stroke is
White on CT scan.
Because that affects everything you do for the patient. If it's ischemic stroke, there's a line of treatment you follow. If it's hemorrhagic stroke, there's a line of treatment you follow. So please, let's make sure that we don't miss it at any point. I won't talk about MRI because the truth is that MRI is not readily available for most of us for our practice.
Oh, God.
It's thought to be the most sensitive one. It helps us
Dr. Hammond, please, do you have you online?
Hello, Steve. Yes, I'm here, but unfortunately, I keep going on and off.
Oh, okay.
Yes. So it's the lights, it's the rain.
Okay, Prof is back. So, Prof, you can go ahead. Thank you, Dr. Hammond.
The devil is a liar. We'll finish. All right. So when somebody comes with weakness or symptom that you think could be stroke, I think it's important that you have differentials. Because not everything that presents with hemiparesis is stroke. And as clinicians, I think we need to be mindful of that. Because I've seen patients who have had, let's say, HIV with toxoplasma be managed as stroke, or subdural hematoma be managed as stroke. So it's important to remember that not everything that presents with hemiparesis is stroke. And that is why you need to take a good history. So if the symptoms started suddenly, it's likely to be a stroke. But if it is gradually progressive, then you may have to entertain other differentials apart from stroke. So I think one thing that cuts across the three presentations that you've listened to is that management of most of the neurological disorders is multidisciplinary. And so in stroke, we have acute care, secondary prevention, rehabilitation, occupational therapy, psychosocial support. And most of these things are time sensitive. So timely assessment and institutional intervention should be performed ideally in a dedicated stroke unit. So what are some of the general emergency things that we should be doing? Number one, you have to check and protect the airway. Number two, check the breathing. If the person has difficulty breathing, see how you can assess, because sometimes they may vomit and they may be, vomitus in the mouth. You have to see if you can suction it out. And one of the things I always tell my house officers, whoever I'm working with, is that, look, when somebody comes to a stroke, frequently check their pulse. Because sometimes the atrial fibrillation or the irregular pulse may not be fixed. Sometimes it's intermittent. So if you check the pulse regularly, you may be able to pick it up, especially if you don't have an ECG or anything. And you know that our ECGs can only do for a few seconds. So really, the clinician who is taking care of the patients should check the pulse regularly. Because if you're able to pick up an arrhythmia, it's able to tell you why the person had a stroke in the first place. The other thing about circulation when you're managing a stroke patient is check the blood pressure. Almost always, all the stroke patients that we are managing in practice have very high blood pressures. So when they come, what we do for them when their blood pressure is high depends on whether it's an ischemic stroke or hemorrhagic stroke. So very simple things. And these are the things that make a difference in the management of stroke. It's not the highfalutin thrombolysis that people are excited about. Really, they're very simple things. Does the person have a fever? If somebody has a stroke and has a fever, our job is to make sure that we identify the source of the fever. Does they have an infection somewhere so that we can treat the infection, manage the fever, and improve the outcomes? What's the blood glucose looking like? If the blood glucose is high, above 11.1, it's important for us to be able to bring it down using insulin. Set up an IV line, give IV fluids if the person is drowsy and cannot swallow. And it's important that I stress that a lot of patients that will come our way will be unconscious or drowsy. So you should assess their airway quickly. If the person cannot swallow properly, then you have to pass an NG tube. NG tube saves lives. For all our stroke patients, 40% of the deaths that we see are due to aspiration pneumonia. So if you can assess swallowing by just giving them about 5 to 10 mL of water to see if they can swallow. If they can't swallow or they start coughing, it means the swallowing is impaired. So pass an NG tube and you'll be diminishing mortality by 40%. And also, of course, assess if there are seizures. If there are seizures, you manage. So these are general principles. These are principles that we can follow everywhere, whether you're in a primary care setting, secondary care setting, or tertiary care setting. These are the fundamentals. So revascularization therapy, well, highfalutin, interesting concept. The person comes with a stroke, there's a blockade of an artery, try and remove the clot, either with a thrombolysis or with a clot remover, so that I can re-establish perfusion. This should be done, of course, within the first 4.5 hours if the person has an ischemic stroke and you want to thrombolize. But for mechanical thrombectomy, you can extend up to about 9 hours before you do that, and all those can be done. A lot of stroke mortality is due to complications. So when a patient comes to you with stroke, you have to be alert that, look, Charlie, there can be several things that can go wrong with this patient, several things. So you have to be alert and you have to be checking regularly to see if these complications are. The way I divide the complications, I group them into neurological complications and then what I call medical complications. So the neurological complications, brain edema, if on a CT scan there's midline shift, brain herniation. Sometimes the person has come to you with an infarct, but it can undergo a symptomatic hemorrhagic transformation whereby an infarct starts to bleed. And that one, if you are not following up with a CT scan or repeated CT scan, you may miss it. And the reason why we know about these things is that in the West, they do repeat CT scans after they've done a first CT scan. But in a part of the world, you'll be lucky if you have one CT scan. And if you have the patient to go and do a repeat CT scan, they'll be looking at you as if you've committed a crime. But if you don't do repeat CT scans, you may not be able to pick up hemorrhagic transformation, especially if your patient is deteriorating or getting worse. It's important to do a repeat so that you can pick it up. You can have seizures, hydrocephalus, pneumonia, urinary tract infection, sepsis, cellulitis, falls, decubitus ulcers, incontinence, symptomatic DVT, pulmonary embolism, and then stress ulcers, acute coronary syndrome, acute pulmonary edema. So to be able to manage stroke, you need to know medicine, basically, because all the complications can come at you at different times in a follow-up of the patient. Depression can set in later on. Dementia can also come in. So there are a lot of complications to deal with in stroke. So I just want to use some case witness to talk about secondary prevention. Now, when we say secondary prevention, we should understand secondary prevention. What does it mean? A person has had a stroke, okay? The person is at risk of developing either a recurrent stroke, it's at risk of developing, let's say, a coronary artery disease, it's at risk of developing other vascular problems. So when somebody develops a stroke, we want to make sure that we put the person on treatments so that we prevent adverse cardiovascular events. A recurrent stroke is an adverse cardiovascular event. If you've had a stroke, you don't want another stroke. If you've had a stroke, you don't want an MI after a stroke. If you've had a stroke, you don't want peripheral vascular disease. So most of the things we do for our patients is based on that principle that, yes, the stroke has occurred. How do I prevent another vascular event? And that's what we call secondary prevention. And the approach to secondary prevention also depends on, to a large extent, the type of stroke that you're dealing with. And that's why we've said it's a tailored secondary prevention, because not all ischemic strokes are the same. But I'll just tell you guys that for all ischemic strokes, if you don't know what you're managing, for all ischemic stroke, give them aspirin. Okay? All ischemic stroke, if you don't know what they're managing, just give them aspirin, and you'll not be far from wrong. All right. So this 62-year-old Ghanaian woman was admitted with a small vessel occlusive ischemic stroke. So this is a lacunar stroke, a very small internal capsule infarct. She's overweight, she's hypertensive, blood pressure is 162/96. She has normal lipid profile, and glycated hemoglobin was also normal. So my question to you guys, if you saw such a patient, would you prescribe just aspirin, which is a single antiplatelet, or will you prescribe a dual antiplatelet, aspirin and clopidogrel? So you can put your answers in the chat box and let's see. Single or double? Dual. So Emilia says dual. Kings Empire says dual. The rest are undecided. Yvonne says dual. Okay, and then what will be your blood pressure target? Okay, Abna says single. What will be your blood pressure control target in these patients? Where do you want the blood pressure to get to as you manage these patients? Less than 130/80. Very good. Okay, great. So basically, for those with minor strokes, the advice is to use dual antiplatelets. But the truth, let me be very open with you guys. I think dual or single antiplatelet is really a specialist thing, if I can put it that way. Specialists like to feel special. So they say, okay, for this patient, I want to give dual, this patient, I want to give single, this patient. But you give antiplatelets, it's fine. If you give aspirin or clopidogrel, it's fine. Because I know I'm not talking to specialists all the way through. So the take-home message is, it is better to give an antiplatelet. A single one is okay. But if you are certain that this patient has had a mild stroke or a transient ischemic attack, and you are confident about it, then you can give a dual antiplatelet. And when you give the dual antiplatelet, you have to give it for just 3 weeks and nothing more. So it appears that the longer the duration on dual antiplatelets, there's a risk of bleeding. Okay, so the BP, some of you say 130/80. Those of you say 130/80 is excellent. For lacunar stroke, we want it below 130/80. But for the other stroke types, we want it below 140/90. So well done. Second case, a 75-year-old gentleman who has a right middle cerebral artery infarction. Take note, he has a non-valvular atrial fibrillation. So this stroke is due to a cardioembolic source. He has atrial fibrillation. He's normotensive, has a previous history of smoking. Well, we couldn't give thrombolytic because he came late. So my question to you guys is a non-valvular atrial fibrillation that is causing this stroke. Question, will you prescribe an antiplatelet or an anticoagulant? I want your answers in the chat box, because this is Zoom, people will be logged on, but Charlie, no action. Their mind will be somewhere. So please put some answers and let me see that you are following. For this patient, will you use an antiplatelet or anticoagulant? Yes. Hey, and I'm a free so. Am I still on?
Yes, please.
Okay. Somebody says anticoagulant. Okay, good. Anticoagulant, excellent. So her cholesterol is 4.3. What would you like to do about it? Cholesterol is 4.3. Are you happy with it? Yes, no. Okay, so you're not happy about it. You want the cholesterol to be way lower, isn't it? So you want to prescribe statins for her as well. I agree. So her HbA1c is 5.8%. If your HbA1c is between 5.7 to 6.4, you have prediabetes. So what are you going to do about the prediabetes? Are you going to counsel her, or what are you going to do? So let's look at the counsel. Okay, let's look at the data, shall we? So this is a cardioembolic stroke. It makes up about 20% of all ischemic strokes. And the evidence base supports the use of oral anticoagulants for cardioembolic strokes. So all those who say cardioembolic strokes, well done, kudos. You are correct. So warfarin is the gold standard. It used to be the gold standard, but unfortunately, it's associated with a lot of bleeding risk. So we are moved away from, well, we are gradually moving away from warfarin-based to the novel anticoagulant therapies, such as rivaroxaban, apixaban, and dabigatran. And for all the major trials that were done, it was found that these novel agents are able to prevent cardioembolic strokes at the same rates as warfarin would do, but the advantage is that they cause less bleeding risk than warfarin. So most of you also said that you wanted the LDL targets to be lower in this patient. 4.3 was a bit high, and wanted to be around 1.8. And so your answer is correct. It's based on evidence from the Sparkle trial, which showed that aggressive lowering of cholesterol lowered recurrent stroke risk by 16%. And we are not talking about 10 milligrams of atorvastatin. We're talking about 80 milligrams of atorvastatin. Okay. And then for the patient who had, we said he had pre-diabetes. So there's also evidence that if somebody has pre-diabetes and you put the person on pioglitazone, that also reduces the risk of recurrent stroke significantly. And now there are new agents, the SGLT2 inhibitors, they've also come on the block, and the cardiologists use the SGLT2 for heart failure. There's a lot of evidence for it, but for us in stroke, the only evidence, it appears to be beneficial in those with hemorrhagic strokes. So I would like to quickly touch on subarachnoid as a roundup. So The cause of subarachnoid hemorrhage, they will present with sudden explosive headache. You'll have sentinel headaches. The headaches are very severe. It's associated with nausea, vomiting, fever, meningism. And then the causes are usually due to aneurysms. AV malformations form about 10%, hypertension about 10%, and then about 5% of cases of subarachnoid hemorrhage, we really don't know the cause. It's idiopathic. And sometimes we think that witchcraft can be implicated here, because I had a patient once who had a dream that somebody was knocking his head with the hammer. When he woke up, the headache was there. When he came, we did a CT scan, there was subarachnoid hemorrhage. So this one, now who caused some? So idiopathic, sometimes all these factors can, but it's just a joke. Don't go and say that witchcraft can cause subarachnoid hemorrhage anyway. They'll fail you. All right, so what are the risk factors for subarachnoid hemorrhage? You can have hypertension, excess smoking, cigarette smoke, excess alcohol use, cigarette smoking, and connective tissue disorders, all causing subarachnoid hemorrhage. CT scan is very helpful in confirming subarachnoid hemorrhage. I'm going to have to check for you. CT scan is very helpful for subarachnoid hemorrhage. So when we do the CT scan, you may see the star appearance on the CT scan, and then the CSF is usually bloody or xanthochromic. So treatment of subarachnoid hemorrhage admits the person, maintain the airway, treat seizures, treat fever, elevate the head of the bed, keep well hydrated. And if the person has raised intracranial pressure, we've used mannitol, furosemide, steroids, they all don't work. So if the person has raised intracranial pressure, either you elevate the head of the bed, and sometimes we use hypertonic saline in a few cases to be able to help manage subarachnoid hemorrhage. So when somebody has had a stroke, you have to rehabilitate the person. So you need a physiotherapist, occupational therapist, speech therapist to be able to do that. Thank you very much. And I'll pause here and ask if there are any questions. Thank you.
Thank you, Prof, for this is another exciting, insightful presentation. Now, as stroke patients, the incidence is really, really going high. Thank you for the hard work and the necessary inputs. I'll hand over to Prof. He has anything to say. If there are questions, Prof is on standby to answer. Thank you. Okay.
Thank you very much for these presentations. At the beginning of my acceptance to be a chairperson, I said, I think that at that time I was muted, that the presenters for this afternoon sessions are very seasoned in their field of medical practice, and they have been deliberately assembled to deliver the issues at hand with a language that will be understood by non-medical people on the streets. But regardless of what it is, some subjects are very technical, that no matter how hard you try, they will still remain technical and terminology intensive. So there is nothing we can do about it but to accept the presentations that we had. So I think that I'll give it to the moderator to see their questions to be answered, and then we'll take it from there.
Okay, thank you, Prof. Dobe. Yes, so if currently I'm not seeing. Okay. Yes, there is a question here. What is the role of tranexamic acid in hemorrhagic stroke, and also any means to give anesthesia medications as prophylaxis in hemorrhagic or subarachnoid hemorrhage?
Hello, am I muted?
Yeah, Prof, we can hear you.
Yes, please. Yes. So tranexamic acid, the evidence from the CRASH trial show that tranexamic acid, when given within the first 24 hours of an intracerebral hemorrhage at a dosage of 500 milligrams twice daily, is able to reduce mortality significantly within the first 7 days. However, you lose the mortality benefit after 90 days of treatment. After 90 days, you're not giving a tranexamic acid for 90 days. I'm just saying that when you give the tranexamic acid within the first 24 hours, it translates to mortality benefit in the first 7 days, but not in the 90 days or 3-month time period. So yes, it has a role. It has to be given within the first 24 hours of onset of stroke symptoms. Prophylactic anti-epileptics or seizure medication, that's they are called now. So the evidence for subarachnoid hemorrhage, there's no evidence that when you put them on prophylactic anti-seizure medication, it can prevent the seizure from happening. In fact, it can be detrimental to the patients. However, recently, some French guys published a small pilot trial for the use of Keppra for prophylactic seizure prevention after intracerebral hemorrhage. It's a very small trial, so it hasn't gone into guidelines yet. And I'll be cautious about using prophylactic anti-seizure medication because sometimes for a very small pilot trial, you may see evidence of benefit, but when you do a larger multi-center trials, sometimes the evidence is lost. So I'll still say that you would, when somebody comes with a seizure, the most important question to ask yourself is, why is this person have a seizure after a stroke? In our experience, a lot of the time, the seizure is due to hyponatremia, for instance. And so you may have to correct the hyponatremia to stop the seizure. Of course, you give drugs to anti-seizure medication to stop the seizure, but often you have to try and look for that line cause. Sometimes it's because the person has a UTI, or sometimes because the sugar is very high. That's why the person is having the seizure. Then you address it accordingly. Over.
Thank you, Prof. That's a very good response. Thank you. If anybody has, because in the chat box, I'm not seeing any question there, but if anybody online,
sorry,
go
there
ahead.
were some questions to me that I haven't answered. Can I answer now?
Yes, no.
Okay, thank you. So there was a question about the age of seizures for the kids who have ASD. We said that about 30% of individuals on the spectrum will develop seizures or have epilepsy. So there are two peak age stages. So the toddlers between 2 and 3 years, and then when they are adolescents, when they get hit the teenagers. So the 30% who would have seizures usually will have it at those peak periods. The other question was Savant syndrome and how it's related to autism spectrum disorder. So Savant skills is one of the features we would see in autism. And Savant skills just means that if you look at the child or the individual as a whole, and you look at their general development, they have an exceptional skill. So this could be in anything. We have people with exceptional memory, exceptional math skills, music skills, children who have not been taught music before but can play Mozart and things. But Savants just tells you that if you look at the general developments, this skill they have is like exceptional. It doesn't compare to their general development. So Savant syndrome doesn't always occur in autism, but can occur in autism also. You can see it also in intellectual disability. There was another question on virtual autism. And that can, so some of these questions were sent to me directly, so you may not see it in the chat. Virtual autism and can it go away? So virtual autism has not found its way as a diagnosis yet in the ICD-11 or DSM-5, but it is recently coming up. It is a few people who have written about it. And that is because these are children who are exposed to excessive screen time before the age of 2 and over 4 hours a day. We do tend to see that they have delayed language skills, they have delayed social skills, and then they also have some like short attention span, hyperactivity. These are some of the features you see in autism, but in virtual autism, they don't really meet diagnostic criteria for autism as you see in DSM-5. They may have more red flags of ASD. And yes, once you take the screen time away, if it is virtual autism, as we know it, the symptoms should regress. So it's not a real autism. The last question was about why there's a delay in diagnosis in the rural areas when it comes to cognitive and neurodevelopmental issues. I think I shall let my senior Dr. Hammond answer that one. Thank you.
Thank you, Doc.
Okay, Marilyn, that was a very difficult one to send to me. And it's not only in the rural areas that we have delay in diagnosis of these neuro-disabilities. I mean, we see them in the big cities also, in the big centers also. I think basically the reason is that in the past we have been very, most of us have been very shy of neuro. And so when we see anything that has to do with neuro, we quickly will say, okay, let's send it to Prof. Dogbe, let's send it to Prof. Safo, they will take care of it. We are very happy to examine the chest and the heart and describe all the heart sounds. But when it comes to CNS examination, we always say GCS 15/15, patients is conscious and alert, no focal neurology, and then we move on. So I think it is changing. And soon we will upgrade our neuro skills and we'll be able to pick up some of these conditions earlier than we used to in the past. There was another question asking about statistics for cerebral palsy in Ghana. We don't have robust data to speak to that, but a few studies have shown a prevalence of about 1 in 300. There was a study by Prof. Dogbe, myself, and other people looking at the trajectory of cerebral palsy across the age span in Ghanaian children, and we came up with a prevalence of about 1 in 300 live births. Another study, quite recent, by Fonzie et al. I don't know who these investigators are, but they were looking at cerebral palsy. These are all estimates in Ghana, and they also came up with 1 in 300, very, very much like what we found, which translates into about 3 or a little bit more than 3 per 1,000 live births, which means that, because remember I said from the beginning that it's about 2.5 per 1,000 live births. So if we are recording something like 3 or a little bit more than that per 1,000 live births, it means that our estimates in Ghana are quite high, and that we probably should look at our obstetrics practices again. And we all know that a chunk of the patients with cerebral palsy are coming from birth asphyxias and hypoxic ischemic encephalopathy. So that would be my response to that question also. Thank you very much. Over.
Thank you, Dr. Hammond, for that excellent response. I think there is a question here for Prof. Safo. Thanks, Prof. We have learned time is very vital in the management of stroke. Imaging and subsequently referring is a big delay. How can we deal with this as health workers?
Hello, Evans. I think at some point, your
It
voice
was
went
breaking.
Yes,
okay,
please.
so I'll focus on the question. The question was, after suspecting or diagnosing a stroke at a district and wanting to refer to a tertiary center, you'll be asked to do an imaging. Meanwhile, referring for imaging to be done and subsequently referring is a big delay. How can we deal with this as health workers?
Okay, so primary issue is if somebody comes to me with a stroke, as I showed you, there are basic things that I believe saves lives. And if you don't have CT scan at your facility, it's not a crime. You don't have it. So airway, breathing, circulation, can a person swallow? If you cannot swallow, can I pass an NG tube? If the person have a fever, if there's a fever, antipyretics, antibiotics, till I get to identify the source. Simple things like if the sugar is high, let me bring it down. And then if the BP is very high, and I don't know whether it's ischemic or hemorrhagic, maybe I can bring it down to, let's say, somewhere around 160. It's okay, systolic of 160, if you bring it to that area, it's not too harmful for ischemic, not too harmful for hemorrhagic, if you don't know what you're dealing with. So I'm not the type that says, how much you might have a CT scan to manage a stroke patient, because I'm aware of the environment in which we practice. So sometimes just, what I say, an APROTEC approach where you are aware of your environment, so you do things at least to save the life of the patient, or the patient is stable enough to transfer the person to, or refer the person to a tertiary center for follow-up care if it's beyond you. And I also say that really after about a month, okay, of stroke onset, it doesn't matter whether it's ischemic or hemorrhagic. Really, the principles of management then become the same. If the person is hypertensive, you have to manage the hypertension to go. If the person has diabetes, you have to treat the diabetes. If the person has dyslipidemia, you have to treat the dyslipidemia. So those would be my rough rule of thumb. If I don't have a CT scan to confirm my stroke diagnosis. Over.
Okay. Thank you. I think we have one or two questions, and then we'll be done, so that I'll give over to Prof. This is, are there primary interventions in the general populace, and are there studies to show correlation to reduction in strokes? Also, any standardized follow-up care?
Look, the number one thing that we should do is manage hypertension, full stop. If we're able to control hypertension in our population, something like intracerebral hemorrhage will disappear. You won't see it again. Because if I see 100 patients with intracerebral hemorrhage, about 95% of them have hypertension as a cause. So if there's something that we can do to prevent strokes and, kick us out of work, like neurologists like myself, treat the hypertension and you won't get strokes. That's the primary advice. Full stop. Over.
Thank you, Prof. I hand over to Prof. Dobe.
Okay. So it's a Friday evening. Very exciting presentations and loaded with a lot of information. But I think there's some cross-cutting take-home messages that the early detection and appropriate interventions are key to the outcomes of the management of these conditions. We should be paying attention to our kids so we can identify red flags and soft signs very early so that we can mitigate the real outcomes of these conditions. It is also important that we pay attention to the risk factors. And then we have differential diagnoses to the things that we diagnose. We are not magicians, we are scientists. So the differential diagnosis will lead us to other areas where we are not suspecting things, so we can find things where they are hiding. And then we have to build multidisciplinary teams. We should be able to work within the teams because this is the complete outcome of what we are actually dovetailing. Yeah. So I think that basically this is where we have come to at the end of this presentation. And it's no doubt that the presenters have done justice to the topics to the greatest extent that is available to us. So I would want to thank Group Exchange for putting all this together and pulling these resource persons together. And then to the presenters and then to the participants who spend all the time. More than over 90 participants have been holding on for a very long time. And this is very appreciated. Thank you very much, everyone. And I think that at this point, we thank God for his grace and mercies for pulling us through this afternoon's webinar. Thank you and have a restful weekend, all of you. Bye-bye.
Bye.